is it's a panel discussion about harm reduction services, and so it's moderated by Becky Cienki. Becky Cienki serves as the Director of Behavioral Health and Special Projects for the Michigan Health Endowment Fund, which is a foundation aimed at improving the health and wellness of Michigan residents, with a special emphasis on children and seniors. In this role, she's responsible for designing and implementing the fund's strategic grant programs, overseeing grant activities, and developing partnerships aligned with the Health Fund's mission. She has spent her career supporting safety net organizations to improve access to quality care and is passionate about improved integration of services and supports. Through her work with Michigan Health Endowment Fund, Becky is also a dedicated member of the Michigan Opioid Partnership. And with that, I will turn it over to Becky.
Thanks, Marissa, and thanks to all of you for being here today and staying till the very end, and all of you for being here till the very end. I'm really honored to be able to facilitate this panel of the real experts in the room, and I thought I'd just level set by giving a definition of harm reduction for those who aren't familiar, but I bet most of you in here are, but I thought I'd grab the SAMHSA definition, which is, SAMHSA is the Substance Abuse and Mental Health Services Administration at HHS. And their definition of harm reduction is an evidence-based, practical, and transformative approach that incorporates community-driven public health strategies to empower people who use drugs and their families with the choice to live healthy, self-directed, and purpose-filled lives. And it emphasizes engaging directly with people who use drugs to prevent overdose and infectious disease transmission, improve physical, mental, and social well-being, and offer low-barrier options for accessing mental health services, including substance use and mental health disorder treatment. And I think there's no better time than now to be thinking about this, again, not being a moment, but a movement to address harm reduction. And if we think about the statistics, it really is critical that we work on improving access to care, with over 100,000 people dying of overdose last year, and with statistics that tell us only about 1 in 10 people with a substance use disorder access treatment in any 1 year. There's no better time to really be thinking about how we get people into care. So I thought we could really start the conversation first having you each introduce yourself. If you could share just a little bit about who you are, where you work, and let's see, I had a little bit more of a question actually than I wanted to, where you work and how your organization supports or deploys harm reduction services.
Sure. I thought you were going to ask for an interesting fact, and then
I
got really nervous. I was like, okay, I'm not
Two
prepared.
truths and a lie, please.
Okay. All right. Well, I'm Colleen Lane, Dr. Colleen Lane. I work at Corewell Health West, so we're integrating with East. So you've heard Corewell a lot, but I'm based out of Grand Rapids. So I work with Dan Wicklund. So we see patients on the west side of the state, so mostly out of Grand Rapids. As far north as Reed City, as far south as Lakeland, so kind of scattered. We have satellite clinics kind of scattered throughout the west, northwest, and southwest of the west side of the state. And so probably the biggest way that we have integrated harm reduction into our clinical practice is by developing a low barrier access point to treatment. So both Dan and I come from an HIV background. So when we joined Corewell, we really kind of took the lessons learned from the harm reduction movement of HIV, who has been doing harm reduction for decades. And kind of when I talk to addiction audiences, the HIV world and the addiction world have not really done a great job of talking to each other until recently. So there's lots of lessons learned in the HIV world that we're just now starting to integrate into the addiction world. And one of these is low barrier, same-day access to treatment. And so we integrated that into our clinical practice and started a same-day walk-in clinic, which is a nurse-led model. And I'll let him talk more about it.
Thank you. I should have asked too, when you talk about what you're doing to address harm reduction briefly, if you can also just share a little bit about how you define it. And maybe we'll skip you, Nancy, and let Josh talk about how if you don't, we'll come back, I promise, how you're defining harm reduction at the RED Project.
Sure. So I look at harm reduction as, so like growing up in our parents' day, they would look at, you had prevention, abstinence. It was a straight line, that's it. Those are our only options. So I look at harm reduction as like a pendulum on a clock that swings in between both of those things. So what about all that space in the middle? And that is what we look at the Grand Rapids Red Project for what harm reduction is. It's meeting people in literally every aspect of their substance use. If they are in the contemplative stage of recovery, if they are in active use and aren't even thinking about recovery, or if they are in abstinence-based recovery. It's meeting those folks where they're at and doing whatever we can to improve their quality of life. Some days that means just helping folks access food. Some days that means helping somebody figure out how they can get an ID. And getting an ID can lead to being able to get a job. And it's those little baby steps that folks take every day. And that's kind of how we look at harm reduction at the Grand Rapids Red Project.
Nancy, would you introduce yourself and share a little bit about how you're defining harm reduction?
Sure. I'm Nancy McDonald. I work at Integrated Services at Kalamazoo. I'm one of the clinical directors there. We are the community mental health for the county, and also we are a CCBHC. One of the programs underneath me, and it's like a badly hidden secret that's my favorite program, is our opiate overdose response program. And so we are a rapid response program for any substance-related emergency in the county. And I can talk more about that later. But we define harm reduction as everything that happens before people have the opportunity to get better. So it's keeping people alive. We've yet to be able to help anyone who's dead. And so our goal is, what do we need to do to keep you alive? We hold hope that recovery is available for everybody, but it's what we do until then. So that could be, it's obviously Narcan kits. It's potentially, thanks for the suggestion about HIV, because potentially it's giving people information about how to access things so that you can have safe sex. It's information about where in the community you can get clean works. So it's all the things that might happen before you get clean and sober.
Dan, would you like to go ahead?
Yeah, hello, I'm Dan Wicklund. I am nurse educator for addiction at Corewell Health West. I define harm reduction as giving the opportunity for people to make informed choices and respecting those choices, whatever that looks like, and reducing the paternalism in medicine.
That's awesome. And Dr. Kocher.
Yeah, so I'm Keith Kocher. Pleasure to be here. Nice to see all of you. I guess a little bit about my bio here. So I'm an emergency physician. I'm faculty at University of Michigan. I think probably my other role here is I'm one of the medical directors of a project called the Michigan Emergency Department Improvement Collaborative. And this is a project funded by Blue Cross Blue Shield of Michigan with a mission to be a catalyst for quality improvement, really. And we have a lot of latitude to decide where to apply our resources and what to prioritize within our network of emergency departments across the state. And a few years ago, we thought there was an opportunity to really do harm reduction around naloxone in emergency departments. And started with some pilot work with another group at Michigan called the Opioid Prescribing Engagement Network. Many of you in this room were part of that work. And have developed these programs to distribute naloxone from the emergency department for those at risk. And we can sort of talk about some of those details. I think for me, around harm reduction, the only thing I'd add is I think it's important to kind of overcome some of this stigma barrier by connecting with clinicians that we do harm reduction like all the time in other contexts. Certainly, one of the things you have to do in the ED is sort of make the case that this is your job and you have some accountability and responsibility for doing harm reduction for this set of patients, just like you might for other patients, who may be at risk from their diabetes. That was brought up, a lot of chronic diseases that we manage, bike helmets for people at risk of head injuries. I mean, there's a lot of stuff that we do in the ED that you can relate to a harm reduction strategy.
Thank you.
Yeah.
I'm interested in hearing more about how harm reduction services first began in the organizations you're each in, and any evolution of that since then, really, if you'd like to start.
Sure. Dan, you want to talk about our Narcan distribution boxes? And
Yeah.
I do want to say, we talked a lot about Narcan. Harm reduction should not start and end it with Narcan, but I do want you to talk about kind of that movement.
Yeah, how Dr. Poland mentioned that prescribing buprenorphine at discharge should be the kind of lowest barrier for malpractice. I think that providing Narcan as well for people who are at risk is the bare minimum. But that being said, that has been an initiative and that is a push, and we have worked here at Corewell to get 30 now distribution boxes in our primary care sites, just to be able to provide that level of no questions asked. You have the EpiPen, you are at risk, you have this tool available, you can pull it out of the box. Harm reduction has also expanded for us as well, doing our walk-in clinic. We have been lucky to be grant funded through this organization and be able to reduce the barriers for insurance. So we will see people regardless if they have insurance, what type of insurance, if they don't, and then getting them connected with those resources. We have internal structures that we can rely on. We just need to get people in the door, and we found that walk-in services, if today is the day, it's available, and we've had great success. I'm actually really proud that we've had 3 patients while Dr. Lane and I have sat here this morning being seen by our clinic. But beyond that too, we've also worked with our primary care partners to establish baseline knowledge of opiate use disorder, substance use disorders in general, and increase the encouragement of prescribing buprenorphine for at-risk patients beyond our borders in the addiction medicine realm. Really providing safety education for looking at high-risk prescribing patterns, mixing high-risk controlled substances, even if they're prescribed. What does that look like? Getting the conversation going that people are at risk, and addiction doesn't discriminate, as we all know, but we need to be looking at ourselves and our own prescribing behaviors just as much as we're looking to the community as a response system as well.
And we have the luxury of not being emergency department providers, so we get to see people sequentially, intentionally sequentially. So we also, like Josh was saying, if folks are not at the point where medication might be part of their recovery plan or where they're at in their recovery, we do have people who come to us where they're seeking testing and treatment for hepatitis C, and that is part of their goal for their recovery in that moment. So we do not require abstinence or traditional treatment for people to be participating in our clinic. So you can walk in to get information about what treatment at any point in that pendulum, what that would look like, and it's testing and treatment for hep C. It is testing and treatment connection to care to HIV, also access to PrEP, which is the medications that prevent HIV.
And I think it goes back to just building trust. We know that this patient population has been harmed by the medical community. They've been stigmatized in the past. If hep C or HIV questions are enough to get you into the door and keep you coming back, that's what we want. We'll take that as a win. We know that recovery may take you a couple of years. Even having those conversations may take multiple visits. That's okay. You're coming back, and we celebrate that.
And recently also wound care for xylazine wounds. Yeah.
That's great. Nancy, can you share more about the evolution of harm reduction?
Sure. Well, so, I mean, I come from a community mental health background, so we've always done person-centered planning, which really is a lot like harm reduction, right? So you meet with somebody and you're like, what do you want? What are your goals? And they might not be, I want to do everything I can to treat my depression or my schizophrenia. People might say, well, I'm willing to do this and I'm interested in doing that. And so you apply that same approach to behavioral health in terms of substance use, and you really are looking at harm reduction. Our program started off with the idea that we would initially respond to emergency rooms. We now respond to any safe place in the community. But that we would just come in as soon as somebody agreed to talk to us. Like, so that's all you need to do is, I'm willing to talk to somebody. You're not necessarily willing to stop using. You're not necessarily willing to enter substance abuse treatment, although if you want that, we'll help you right away. You don't even have to be willing to take a Narcan kit. Maybe you just want to talk to somebody. And so that's where we start with. So you're willing to talk to us, we come in. And we decided that it was really important to not only make it easy for the people we were treating, but we had to make it easy for emergency room staff. Because having worked in an emergency room before, the more barriers you put in place. So we try and employ a harm reduction strategy with our ER staff as well. You don't have to correctly diagnose the person. You don't have to identify what billing code you're going to use. We're not going to charge anything. We give you one phone number to call 24 hours a day. We will always respond. We'll take care of it from there. So we've kind of tried to employ that approach, low barrier, make it easy. We'll come out if it's wrong, like we'll deal with it later. So that's our approach with harm reduction.
Thank you. Josh?
Yeah, so the Grand Rapids Red Project started in the late 90s due to the HIV epidemic. So at the time, it was determined that like 25% of all reactive HIV cases were a result of injection drug use. So the mayor at that time authorized us to start the syringe access program that started in the early 2000s. And from that program, we progressed to having not only our syringe access programs providing sterile supplies to folks that were injecting substances, but also having medical case management, transitioning to overdose prevention programming, to recovery coaching, and currently I do recovery coaching. We have a drug checking program now where we can, folks will bring in a substance that they want to have checked. We have an FTIR machine. We can check those substances to determine if it's got fentanyl, if it's got xylazine. We're able to check those substances for folks and give them an answer within 20 minutes. And we do, like I was saying, overdose prevention. So we go out and educate the community on how to use Narcan and where you can get it for free, which we also give out. I do our post-overdose response program, like you were saying, a rapid response program. We have that at Red Project too. So anytime someone's had Narcan administered to them for any reason by the local police departments or EMS, we're given follow-up information to connect with that individual. Not to force anything on them. Sometimes I just carry a backpack with fentanyl test strips and Narcan in it and my business card, because folks are a lot more likely to talk if you come bearing gifts. And if I pull up and I got a backpack full of Narcan and fentanyl test strips and I'm like, look, no pressure, let me just tell you what we do. Maybe they've heard of us, maybe they haven't, but they're a lot more willing to talk when you come bearing gifts. And then we also do, like I was saying, we have the recovery coach, and our jail program. We meet with folks in the Kent County Jail who are on a MOUD, who are receiving the medication in the jail. So this way, back when I was getting arrested all the time, this wasn't an option. So now we're able to meet with folks while they're incarcerated and put together a plan, put up goals for folks to have for post-release success. Because every time I got out, I was kicked right out to the streets and I had no resources whatsoever. So we try to meet folks in that process and continue walking alongside them post-release.
Thank you. Dr. Kocher, do you want to share more?
Yeah, I certainly agree with the panelists that like harm reduction is certainly a wide range of services. I think we have focused very intentionally on naloxone in the programs that we built, in part because we felt like that was probably the easiest case to be made and the most impactful intervention available, and have had as our gold standard the goal of delivering naloxone directly into the hands of the individuals so they walk out with the medication and not do our best to reduce barriers around having a prescription but no way to pay for it, not having transportation to access it, so they literally walk out with the drug in hand. And the reality is, like, as easy as that seems to create a program around, it's surprisingly hard. And I think you have to recognize that emergency departments come with a range of resources and realities around that. We're talking about small hospitals that don't have pharmacists. They don't have a way to store the medication. They don't have a process built out to order it. There's sort of regulations around how to do it. So it's actually quite challenging to build an actual process, stem to stern, to work. We do our best in part to be cheerleaders, to be project managers, to support with the actual materials, to be advocates, to do even some data collection and sort of audit and feedback around that. But really it's the people on the front lines that are doing the work, and we're just doing our best to support them the best we can, and recognize it's a continuous improvement process. You have a goal and you try to get there, but recognize that people will be at various points in their maturity and start building those kind of programs.
Yeah, thank you.
Yeah.
Harm reduction services, for various reasons, can feel really challenging to financially support. I'm wondering if we can start at this end and have you come this way, but just sharing a little bit more about how you're doing that in your organization.
Totally agree. Sustainability is important to consider and recognize. The way that we've approached this is to actually support each of these emergency departments. Right now we have about 40 of them with the actual materials, so we actually create a kit. But the biggest cost is obviously the medication itself, naloxone, and we actually rely on the state portal to supply the naloxone. And you know, I have questions in my mind too about if the portal goes away, you know, how do you sustain these kind of programs? Certainly, ideally, don't want to pass that cost on to the patient, as that just creates another barrier, as we were sort of talking about earlier. And so I do think that's like the biggest risk for sustainability. Maybe, I don't know, something we can talk to.
I completely agree. That keeps me up at night too, is what happens when the state stops providing it for free. I think the other thing to recognizing working in a large health system is reimbursement. We've talked a lot about recovery coaches and the value of them, but there's no insurance reimbursement. So talking to hospital administrators, why should I bring this on? One of the things that Dr. Lynn and I have had to do a lot of elbow rubbing with administrators to paint the picture of value, which is also difficult too, because how do you measure, did they avoid the emergency department? Did we know that they were going to go to the emergency department? Painting value is critical to keeping harm reductive services even in the conversation as a hospital system, but also showing the outcomes, I think, and telling the stories of what we're doing is how we've gotten buy-in. So that's what I would encourage is, I prevented this overdose. This patient presented saying they would have gone to the ED, but they came to me instead. That's how I've been successful so far.
You want to know how we keep the doors open?
Yeah, how you're financially supporting the harm reduction work in your organization.
Okay. Well, I'm a recovery coach, so I don't. So this is more like our executive director is one of those like beautiful mind people, like who sees numbers when they sleep. So like grants, donations, like all that kind of stuff. The craziest thing to me is like we're a harm reduction organization that started as a syringe access program, and it's the most stigmatized thing that we do. So it's the hardest thing for us to fund and find funding for is our syringe access program, which is literally the reason we exist and how we get people to come through our doors every single day. And multiple people. See, I had always thought that I like coined the plant the seed phrase, but now I've heard like 3 people say it. All recovery coaches have said this, and I'm like, shit, man, I thought I had come up with that. Turns out I didn't. But yeah, so like that's how folks coming in to utilize our syringe access program is how the seed gets planted to maybe they'll want to one day talk to a recovery coach, not necessarily about being abstinent, but like maybe they will want to get, on a medically assisted treatment of some kind. And that seed's planted by the folks that come in and utilize the syringe access program, which is the hardest thing for us to fund.
Yeah, good point. We have a variety of grants. It is incredibly hard to fund this work. So we have a grant from our PIHP, which I very much appreciate. It's not a terribly large grant considering what we do, so we have a variety of strategies to put things together that involve the fact that I'm notoriously frugal. So we have 2 full-time staff associated with this program, but we run a 24/7 program 365 days a year because we employ a lot of contingent or on-call people. So we pay like a lower rate to be on call. We market towards people who are in recovery. We help them get recovery coach certification done. We write grants for me to be able to send them to trainings. We pay a certain rate when you get paged out on call, and we know as a result of the way that we hire people, these are people who are like new to the workforce, which is super cool, but we're always gonna have to be hiring. Because like we get these coaches, they're fantastic, they're like my Saturday person, they work Saturdays, and then they're like, hey, I got my certification, Nancy, and now I'm leaving for a full-time job. And I'm like, that's awesome, man, love you. Now I gotta hire somebody else. So we get really good at hiring people over and over and over again. So that's, that's something that we do. This is an add-on to my job. The other staff who help support this program, all the master's level clinicians underneath me provide a lot of the clinical support and supervision, and I just add this to the jobs they already do, and I'm like, guess what? I hired you for this, and now you get to support my other program that I really like the most too. And so then they do that for free, so we don't get any funding for that. We have, because we're a CCBHC, we would be able to bill the peer recovery coach code, which by the way is like reimbursed at a really low rate. And also, in order to do that, you have to already have a person-centered plan from the person, and they have to write it in their plan. So there's a ton of barriers to being able to bill recovery coaching, but we can, at times, bill recovery coaching. Because we're a CCBHC and my staff, I help them all get their CADC credential, we can bill the H0002 brief screen code. We have a contract with our PIHP to do that, so I bill the HU2 code, is the acronym we use for it. And then we get a prospective payment potentially for some of those folks, so there's like a little bit of other money that's coming in. And then we just try and be incredibly helpful and friendly to like our emergency rooms. Hi, Dr. Ford, thank you. And to our local shelters, and to the Sheriff's Department, and to the Police Department, because in the event that our PHP pulls my funding, people like me enough that they're gonna give me money. Is like my whole plan for keeping everything going, because this really is like incredibly important work. We really help a ton of people. We have a lot of good cred in the community, and so I feel pretty good about that, but you're always pulling on things. And there's no way I'd ever get private insurance, I think, to pay a dime for this, and we don't have any barriers. So as the community mental health, now we're CCBHC, we serve everybody, but historically the Medicaid population is who I've always served, and I understand all the stupid rules around that, can figure it out. Figuring out how to navigate like Priority Health or Aetna, that's really hard too. So like being able to understand that and pulling funding together is a thing. I spend a lot of time on that.
This all speaks to the value of data. So there's a dearth of research and published data in addiction medicine. So when you are making the case to your administrators, we just got a text message when we were waiting to be mic'd up, can you find articles on walk-in data for the walk-in clinic that you're doing so we can do an RFP for Montcalm County? Okay, we'll try to find something. But we made the case for our walk-in data around, or walk-in clinic around the data that exists in the HIV world. So we have to be collecting data and publishing it. Mm-hmm. I did not imagine myself doing research. I am a reluctant researcher, but it is essential. We have to be doing IRBs and we have to be publishing this. That is how we're gonna get people to fund what we're doing.
You and Dan have both talked about the need to share more about the impact of the work you're doing, and I'm hoping that you might be able to share with us any of you, any success stories, share with us the reason why you're an advocate for harm reduction in your organizations.
I have a story that I get a little choked up, so I apologize in advance, but when we started our walk-in clinic, and I know we'll talk a lot about it, but it's just like been the success of our program for the last couple of years is, it was just Dr. Lane and I staffing it on a Tuesday afternoon, and we expanded it to every day of the week, besides weekends. But that being said, we didn't realize that the impact of word of mouth that would have in the community. I talked about we're diverting the EDs, they're coming to us. One of the most impactful stories that I saw with this was a patient that was in acute withdrawal, came into our office, and had Dr. Lane and I's name written on a little piece of paper in her bra that she had gotten from a recovery house, and walked in saying, I was told to follow up with these two people. That's why I'm here. And they had difficulty with CPS. They had a bunch of kind of co-occurring conditions going on, but they still came in, and we knew nothing about them. They hadn't touched an ED, but they came in and asked for help, and they just said, where do I start? I was told you could help me. So yeah, I think about that patient quite a bit.
Thank you.
Me?
Sure.
Oh,
you all can just
bouncing around, popcorning it.
I like it.
Yeah, so I mean, every day as a recovery coach are success stories. Some, talking about this walk-in clinic has been so huge for our clients at Red Project because, again, some of the places we first encounter folks is the syringe access program, and that's folks coming in and saying, like, I'm sick, do you know how I can get some help? Do you know how I can get in? It always used to be, there was always a gatekeeper in Kent County. For anyone familiar with Kent County, it was always, Network 180 is a gatekeeper. So it's, when somebody is asking you for help, they want it right now. They don't want it tomorrow. They don't want it 2 days from now. They want it right now. So I think of actually a couple who came in asking for help. We were able to get them into the Center for Integrative Medicine literally that day. And that was a catalyst that kicked off the process that happened after that, which included them getting their kids back, being able to work full-time jobs, and are now in, got housing through a local community program that allows, you know, they only have to pay like $50 a month, and they actually had housing, but it started with them walking into the syringe access program with nothing, with kids who were in the system, to now they have their own place, they have their kids back, and they're working. And this isn't just a unique situation to just these folks. This seems to be, this has been happening consistently for the last couple of years, thanks to the walk-in clinic at Center for Integrative Medicine.
We started this program thinking this was going to be an ED bridge clinic because that is the data that exists in the addiction world. What our data shows, we haven't published it yet, but we are going to publish it, is that about 20 patients out of the almost 800 have come from the emergency department. Very, very quickly, everyone in the community realized they could just come to us. And a lot of it was because of how they were being treated in the emergency department, and that it was just quicker to come to us and to get what you needed, and you would feel better quicker. We have buprenorphine on site, so we can treat your acute withdrawal. There was not a gatekeeper. It was much lower barrier, and so that is what ended up happening. So this is a unique model that really, right now, the only data that is published is from Canada. This is what they're doing in Canada and Vancouver. So, and it works, but we need more people doing it. It also works, Josh also works at the jail program. People are unpredictably released from jail. And so if you make an appointment, it's not gonna work. You have to be able to go to a place when the judge decides you're out that day. So if you are doing a traditional 9 to 5 appointment, it's not gonna work. So we can't set up programs that are convenient for the medical system. It has to be convenient for the person and the patient.
Yeah, we started in 2017, and we've had 4,300 requests for screens. We call them screens, I don't know, I guess because that's what we use on the mental health side. But anyhow, so we've been around for a little while, and we've now gotten to the point where I've hired people who are like, you know, I was in the ER, and this coach came to see me, and then a year later, I got clean, because the whole planting the seed thing. Because most of my staff are recovery coaches. So that's incredibly rewarding. You see somebody who's moved to like working in the field. And then, you know, we have had, it's interesting, there was like a fair amount of reticence about the idea of putting recovery coaches in some of our hospitals. And subsequently, one of our hospitals, I was there for a different reason, and the staff said, you know, you guys came to see my daughter. And I never thought this would happen to me, but my daughter was there, and you guys came to see her, and I was so relieved because I didn't know what anybody else in the hospital, how they would treat her, and I knew that your coaches would come out, and I knew how they would treat her. And so that was really meaningful for me. So it was nice to hear that.
It's incredible.
Yeah, I mean, I think I have like kind of 2 stories of impact. I feel like I was hearing a theme of the course of today about when these programs to be launched. We launched ours also in the middle of like the beginning of COVID, like, you know, spring 2020. But like over the course of the last 3 years, we've distributed upwards of like 6,000 Narcan kits through our network of emergency departments. Hard to know, you know, how many lives we've affected necessarily with those numbers. But in contrast, you know, just the power of stories, we had like a simple survey on our Narcan kit package. Not that we were expecting a lot of people to respond to it, but we had a couple responses, and like the most powerful one was, "Thank God for your program, like you saved my son's life." And that is so much more powerful at times than like the number. And I think being able to at least be able to feed back, you know, the power of what you can do, along with the data, is going to make a difference, I think, in sometimes people's calculation around the importance of this kind of work.
Thank you.
Yeah.
The work that you're all doing is transformative, it's systems changing, it's really hard, and it's hard to do such significant change without running into barriers. Can you share with us some of the barriers that you've experienced, and if you've worked around them, share that too, if you could.
Yeah, I can speak to the barrier of implementing our walk-in model. The biggest barrier were our medical providers. So the latest adopters were the people who are trained and used to working in the medical model, who were very nervous about a system where we're saying, okay, we're gonna have people who are just gonna walk in the door and we are going to work them into your schedule, and who hadn't been used to working in what's called a nurse-led model. So the way that this program works is that if a patient walks in the door and it's the day that they are there to be seen for whatever they need to be seen for, they are seen by the addiction nurse first. So they're seen same day, not same moment. They're kind of worked into the schedule. We have about a 20%-ish no-show rate. So there typically is enough time in a medical provider's schedule to work in patients. But what Dan and I ended up doing was just saying, we'll just do it ourselves and show you how it works. So Dan started in our clinic as the addiction nurse, and then I was a medical provider, still am a medical provider. The biggest champions were our front desk and our medical, our MAs, because they were the people consistently turning patients away. So they were the ones at the front desk having to say, we don't have any openings today, sorry. Oh, I can see that you are hurting and that, you know, I wish we could see you today, but I gotta turn you away. So they were the ones that were super excited that they no longer had to turn people away, and would get really excited when they'd say, oh my gosh, we have a walk-in here, yay, and get really jazzed about it. So they were the champions, and then it trickled down to a couple of providers who were the early adopters, and then of course we had the stragglers who were kind of the late adopters, but that's how we made it work. Had a couple of champions, and then it was the frontline staff who were the ones that were having to do the hard work of staring somebody in the face and saying, sorry, not today.
I think for us, one of the, so we have a variety of grants. Again, most of our money comes from our PIHP, and I'm super grateful for them. We do use PA2 funds. Somebody mentioned PA2 funds. So we snag some of those, and we use a variety of other funds. They always change what data they want from me. Like midway through the reporting period, I get told, oh, by the way, now I need you to report on how many of them were veterans. I'm like, dude, I don't know. Like, they saw them at 3 a.m. I don't think that was the first question they asked. But so now we collect just a stupid amount of data so that I'm prepared for when they change the reporting requirements so that I can fill it all in. And so, yeah, that's been the biggest barrier for me, is that people change kind of like the rules about what they want, and we just pivot. I typically ask our coaches to do the best they can to get the data, and then we have like a variety of people who enter data afterwards for us, because we try and make things, like at 3 a.m., nobody's gonna capture good data and enter it into a database in a reasonable way. So we've tried to build in, pull people from other job duties and have them do like the data entry portion that we need. But that's really been hard for us.
Yeah, so with the folks that I work with, it's navigating and working through systems that are built against the folks that I'm working with, navigating and breaking through the red tape that's put up everywhere, from you know, wanting to get on an MOUD. Sometimes folks just want methadone. I will tell folks what the easiest route is in regards to, if you want it today, here's where we can go and get this done today. But it's navigating those systems of, well, if you want methadone, here's what we're gonna have to do. There's a gatekeeper, and you're gonna have to go here, and they're gonna have to fund you, and we're gonna have to sit there for a couple hours. I'll be there, and I will, you know, I will advocate for you in this moment. But just so you know, we're gonna have to sit there for a few hours. So it's navigating systems that are not exactly user-friendly. Just being there with clients and sitting there, walking alongside them, not forcing them along into anything, but walking alongside them. But those are kind of the biggest barriers we have, because folks are looking for something instant and right now, and if it's only one thing they're focused on, sometimes, like you said, pivoting, we sometimes have to call an audible and pivot towards, okay, if you want to do this now, here's what we can do to get this to happen now, as opposed to this.
I think my biggest barrier is going back, if I want this now and this is what's going to work for me, is again, working in a large health system, nothing moves fast. So policy, procedure, going through the rigmarole of updating who's the auditor on this policy, or Corewell is currently in integration, so now everything's on hold until March, but I have patients dying in my emergency department. Some of that administrative fluff is my biggest barrier, but I also think on the flip side of that too is the legislative side of it. So making sure that reimbursement is there, incentivizing new providers to come and work in addiction medicine, knowing that they will make less money by going into this than another specialty. So balancing kind of heart work with hard work is something that's very challenging. But yeah, it's worth it.
Yeah, many of these barriers obviously exist for our programs too. I mean, one of the things I'd add is I think it's important to recognize kind of level setting on just the reality of what the ED setting care environment is like these days. You know, it's a pretty stressed setting. There's a lot of burnout. There's a lot of staffing challenges and deficiencies. It is the location where all the outpatient failures show up. It's the location where all the inpatient failures show up. There's waiting times and boarding and crowding. And you have to be able to cut through that noise, recognizing that there is a set of priorities that are going on sort of in the background that you're trying to cut through the noise on. And you know, meeting them where they are, same, I guess, message around harm reduction, and recognizing sort of you got to fit within that set of priorities. And then you know, for this kind of program to be successful, it's not just about the physicians. It's like figuring out how this works with the nursing, the pharmacy, the handoffs that occur between, you know, those job families, and obviously start creating a process behind the scenes that works in concert with all that. But I think just recognizing some of the challenges that, you know, around just working in the ED these days is really important as you begin to think about how you connect with that spot.
Thank you all. Stigma and bias can show up in harm reduction in all sorts of different ways. I'm wondering if you can share with us how you're addressing that with your peers, leadership, patients in the community when you're talking about the work that you're doing, any ways that you've addressed stigma and bias.
So Corewell Health, all, or at least in West, at this stage, all new prescribers or providers who enter the system go through a mandatory 1-hour training that goes over, you know, fundamentals of addiction, talks a lot about stigma, talks about the intersection of documentation and liability and legality, and not just, you know, doing what's ethical and what's, you know, CYA for everyone who knows that, in the sense of documentation, but also what's going to be read in medical records by every other provider that touches this patient after you have documented this. So I think, you know, addressing bias in language is super important and really the crux of moving a lot of this work forward.
So Dan gives that training, he's being humble. But a lot of the role that we created at Corewell West is the nurse educator role, the addiction nurse educator role. So not only does Dan give that training, but he also gives trainings to primary health, as well as every single specialty about opioid safe prescribing, as well as combination medication prescribing. And what this has achieved, not only with education, it has also helped build some collegiality among especially specialties. So when we started low barrier hepatitis C treatment, that was not, as you might imagine, well received by GI. But when we started doing our education and introduced ourselves and started to explain why we were providing this service. It actually helped build bridges, and we are now getting consults from GI for their severe alcohol use disorder patients. So our kind of education has inadvertently built bridges and lowered these kind of imaginary
silos.
yeah, these silos that were existing. There's also a very kind of hard relationship with our palliative care team. We don't have a great pain service, so there's a difficult understanding with patients who live with substance use disorder and also chronic pain, or patients who just have chronic pain and don't have substance use disorder. They have a hard time finding a medical home. And so with primary health, palliative care, and sometimes oncology, there's been kind of this hands-off approach. And so by having a nurse educator role, that has really helped provide a conversation that has not been happening and gotten voices into the room where everyone feels like they can actually talk about this now. So.
Yeah, we, in terms of bias and stigma, so as a community mental health, we've had peers, we've brought peers into all the programs that I oversee. So I think it's really hard to maintain that kind of stigma when you're working with people who self-identify as, hey, I'm someone who has schizophrenia and you're serving me. So we thought, correctly I think, that the same thing would happen by bringing recovery coaches in, so people with lived experience with addiction. And so, you know, if they're in your hospital every day, or they're in your psychiatric clinic every day, or now we have our coach going into our jail 3 times a week, it's hard to like talk crap about people with addiction when the nice guy who you see 3 times a week who comes into the jail, who you all like so much, hey, he's a recovering opiate addict, so maybe you better talk a little nicer. So, I mean, proximity really helps. So I think that's a big piece about bringing recovery coaches and peer support specialists in. It's hard to have these erroneous ideas about what people with addiction or mental illness are like when you suddenly get to know them. So that's the main way that we've tried to approach this.
Yeah, and the way I look at it too, it all starts with language and the way we speak about substances. For instance, you know, my second day on the job, I stuck myself with a syringe, and I remember somebody who was working there saying, he has lived experience, how could he have done, like, how did he not? And I referred to it as I stuck myself with a dirty needle. And someone corrected me and said that's actually a used syringe, because if you refer to it as a dirty needle, or you refer to someone as clean, that insinuates if they're using drugs, they're dirty. And I had never thought about it that way. And it was that one conversation, one time with one person referring to the syringe as it's not dirty, it's a used syringe. People who don't use drugs, they're not clean, because that means that people who use drugs are dirty. It makes folks feel that way. So changing language, you'd be surprised how quickly, you know, my dad's old school, and he refers to now people, you know, he doesn't say junkie anymore or anything like that. He refers to it as people who use drugs, and it only took me referring to folks that way a few different times. So you'd be surprised how quickly we can get people, the stigma attached to language, how easily that can change by just a conversation.
Yeah, I mean, I like a lot of these points. I mean, there's no switch on for changing stigma. Certainly recognizing it's a long-term challenge. You know, it's something about creating the right social fabric that allows you to check each other around language, along attitudes. I think a lot of it is identifying champions, probably people that are personally impacted by the opioid epidemic, and allowing them to, you know, when they feel comfortable, sort of telling their story within sort of the units and, you know, emergency department in particular, that are going to start to make the difference. Yes, you can sort of talk at them with data and stories, but I think it's also about sort of how do you create the right environment to allow stigma to be overcome and challenged.
That's great. Thank you all. Before I ask other questions of our panelists, I wanted to pause to see if any of you in the audience have questions for them. All right. Yep, a couple over here. Just one.
Keith and I started to chat about us getting involved in the Open Medic, and I did a little pilot project, and it was like 95% of Medicaid, this was in 2018, I believe, in a small cohort of patients, like 40 patients, but 95% had no copay for Narcan's nasal spray back then, and I would assume maybe that's gotten better, but I don't want to assume falsely. And so that was a barrier that really didn't exist. And at the time, we had a robust pharmacy staff that would come down and bring meds to patients before being discharged. So they're actually getting the Narcan in hand before they'd go. So if we ever came to that time where we don't have that again, and we had the pharmacy staff to bring the meds down, which we don't really have now, but that would be like one of the thoughts that we would have to, med delivery in the ED with script. And to Dan's point as well, I think you said it really well, like that should be the lowest barrier with anyone with an overdose. And I hesitate to escalate it to malpractice, although I share the sentiment, but what I think we definitely could be doing in our hospitals is making these cases QA material. Mm-hmm. So we already QA about not giving the right antibiotics for soft tissue infections, or somebody comes back to the ER 72 hours late, before or after an admission. Like there's all these metrics, but these should definitely be on our filters, and that would be how we start to raise the standard of care. Sorry, it wasn't a question, but you just had my wheel spinning, and I got a microphone again.
It's a great point that you brought up the QA thing. We actually did that internally, and we actually increased our naloxone co-prescribing by 47% just by putting in a BPA into the chart that says, hey, this patient's being prescribed opioids for longer than 60 days, they're at risk, or they have a recent overdose. He left the room, but Dr. Kuhl is an ED physician, and he's been working with me to get that in our ED spaces as well. So patients are leaving EDs inpatient and outpatient with this kind of BPA firing.
And just a word on naloxone, it is now over the counter, so the nightmare scenario is that Medicaid would stop covering it, just like they do Tylenol. Mm-hmm. So that's the nightmare scenario.
Yeah.
Mm-hmm. I don't know if anyone's tried to buy it over the counter. I haven't seen it yet, but people who are posting on social media, it's like $40.
42
out of pocket?
Specifically, if anyone wanted to know.
So, yeah.
Is there another question in the back of the room?
I know we talked a little bit earlier, but I didn't ask you guys, have you guys have any plans of incorporating the family recovery coaches into the program? Because I know on the east side, we, like through Families Against Narcotics, we use a lot of their family recovery coaches. Even if the patients don't want help, sometimes the parents or the spouse, we're able to connect them with the family recovery coaches.
So we partner really closely with the Grand Rapids Red Project for peer recovery, just within our greater Grand Rapids area. But that being said, we have, with the limited reimbursement and lack of data to show retention and care, some value to the administrative teammates. It's difficult to make that case long term. So we are actively seeking grant funding to support peer recovery that we actually house internally.
Right now we refer to community partners.
Yeah.
So we don't apply our own.
Yeah, we do respond to family members oftentimes, so that's one of the things that we've marketed to our ER and to our local primary care offices as well. Like if the patient doesn't want to see us, but their mom does, you can page us out. We will respond 24/7 to family members. And we do get family members who call us. Our local Families Against Narcotics gives us our Narcan kits, so shout out to them. And then one of my other 24-hour programs, we employ family support partners to go with us when our mobile response program goes to see youth. So we started talking with the people that I employ on call, because again, I'm notoriously frugal, so I have more on-call people that I just pay. So family members that we pay to be on call about, hey, would you guys be willing, ever to connect? I can pay you a little bit if you would be willing to connect with other family members. So that's the next step that I'm trying to make people do more than one job. to make the money go quicker. So that's something that we're thinking about. But right now, yeah, we do respond to family members. We get a fair amount of calls, like a few a month, from family members who want to come in and get an Narcan kit. We often link them with FAM, but they can also come to our offices. We have a 24-hour urgent care center that just opened, so they can come there. We have Narcan kits 24/7 that we can give people from there.
Just have a quick follow-up. PHP here again, funding chats. I do believe you're currently in Region 3 as PHP.
We're SWIMBA, right? That's 3.
Oh,
yeah,
I was
bad
referring
numbers.
to Dr.
Oh, sorry.
Sorry. So, were there any discussions about becoming an OHH?
Sorry.
Everything that you're currently providing falls under coverage of an OHH, Opiate Health Home. Are there any discussions about becoming one? Because that way you're just collecting information on everything you're currently providing. And, you know, with 250 clients, you would be approximately in $1 million revenue a year. Where are you at with that? It's possible.
It's possible. I don't, so we cover, so right now, I don't know if this would actually fall under the possibility because our hub is in Kent County, but we also have satellites in Big Rapids, Reed City, Lakeview, Greenville, Muskegon, and plans to also expand likely to Kentwood, Ludington, and then other regions, depending on where the hotspot map sends us.
We have 23 locations that are health homes, and some of them are also BHH, OHH, and AHH, alcohol health home, and some of them have satellite offices, so technically we have approximately 50 locations. So the more locations, the better, technically, as long as one of the center locations is designated as such, you would be able to go ahead and actually complete reimbursement through all the locations that are qualifying, as long as you have appropriate staff. But by the looks of your team, you already have more than half a staff that is needed.
Well, let's chat.
Let's chat.
If you're willing to fund me,
show me the money.
Yes.
Nice.
I know you said at our table, but I did have a question. How about people under the age of 18, you know, like children? How do you address that?
So I'm Med-Peds trained, which is pediatrics and internal medicine. So I love to remind internal medicine doctors that they can see young people, including adolescents. So we see 13 and up.
Any other questions from the audience?
We did have a couple come in by text, but I want to give anyone else an opportunity. So this might be beyond the panelists, so if anyone else in the room could add to it, that would be great. But there's a question about if anyone uses their HelpNet or employee assistance program to address MOUD.
So we internally, because of confidentiality, we don't get the direct referrals. They're referred to a psychiatric intermediate and then get a referral, you know, that way. So there's a little bit more of a step that we don't get an internal flag of, you know, a Corewell employee has a substance use disorder and wants to be seen. But they are ultimately connected with the internal, at least for Corewell. I can't speak for other organizations.
Thank you. And one more, if there's any, how about tribal interactions? Has anyone been able to connect with their local tribe regarding the project?
So we actually were last weekend at a conference for, so full disclosure, my twin sister is the representative for the tribes of the Western District of Michigan. So all of the tribes from Northern Michigan through the Southern District. So Dan and I have been doing a lot of education for the local tribes. So we spoke at the Pokagon tribe this last weekend and have been setting up educations for other tribes throughout the Western District and the UP. So very interestingly, my twin sister is a federal drug prosecutor, which has been interesting, works very closely with the DEA. So it's been
Interesting.
It's actually very interesting collaboration and education overlap, which has led to a lot of change in their practice and their language, and also invitations to these types of conferences, which has been very helpful. But yes, especially because of the overdose numbers that we've been seeing with our Native American populations, Dan and I have been doing a lot of education with them. And if anyone's interested, let us know. We have connections.
That's awesome. Well, thank you all. You've inspired me as I head home today. I really appreciate the work you do in communities every day and your time here today. Thank you.